3, 2, 1, rolling. Namaskaram. I am Dr. Sivasankar Dalai, Chief of Neurovascular Intervention at TEVAR Hospital at Visakhapatnam. Wish you a very happy Independence Day. Today, at the second half of the day, we are doing a very complex aortic intervention. Basically, this patient is having a large aortic aneurysm, very large, in fact, and so the debranching is already done by my brother, Dr. Karunakar Pari. He will be joining us shortly. So in the debranching, we have taken a large branch from the large graft proximal part, which has gone from the ascending aorta. And the one part has gone into the innominate. The second branch has gone into the left carotid. The third one has gone to the left subclavian artery. And this part has been already done. So we are going to go ahead and graft this aneurysm right now. So Dr. Pari is here already. So he will brief us what surgery has been already done. Meanwhile, what interview? Why black? Okay, we try.
Good morning. I am Karunakar, cardiothoracic surgeon at TEVAR Hospital. This patient is a very complicated aneurysm with the intramural dissection is there, and the aneurysm is extending from arch and descending out. So it is a very difficult case to do any surgery. So we have decided for start hybrid approach. So surgically we have done sternotomy and we have done debranching of both neck vessels and left subclavian artery. As the origin of the subclavian also was not, so we have given graft to the distally to the subclavian artery. So the neck vessels are debranched. Now we will put the stent which will cover the large aneurysm extending from arch aorta and descending further.
Perfect. So plus supposed exchange wire आपण pin gown pin So we have approached this aortic arch already. So we are couple of minutes into the procedure, and so we have gone into the ascending part of the aorta, and can I have the M+ superstiff exchange? Give me. So we will exchange our diagnostic catheter for a pigtail so that we understand what is it looking like. It's a huge aneurysm. You can see this aneurysm is dilated almost like 8 centimeter in diameter. So we are exchanging this diagnostic catheter into a marking pigtail. Can I have the lead? Just a minute. Can you post the images? You can ask Vinod to explain the images on the laptop for the understanding of the viewer. Just a minute. Vinod, please explain the images. Yeah, go. The pigtail. Mark a pigtail. We are ready for the graft already. Injector.
It was a little bit
No.
and sternotomy it was
No. Large aneurysm. So as we have seen the detail computer tomography images that is a very large aneurysm. It's having large two sacs, it's huge. So we have crossed the aneurysm, we've gone into the ascending, and we've gone beyond the proximal connection of the debranching graft. Our idea will be to start deploying the graft from just distal to the debranching graft and exclude this aneurysm from circulation. We'll be using two tapered grafts. The starting one will be around 38, 32, 200. Within that, we might go with about 36, 32, 160. So this is our plan. Stop. Slow. Stop. Stop. Okay. Beautiful. Great. PSI 600, 20, just inject about 15 ml inject karo. Okay, inject 20 ml per second, 20 ml. It's a large aneurysm. We like some.
20.
Yeah, 20. Go LAO. LAO 35. Take care of your equipment. More. All right, little more. All right. Mag Toko. Reduce the mag completely. Yeah. Right. Table please. So we will try to understand the morphology of this aneurysm now. So I'll request for apnea. Are you ready? Prasad, are you ready? Apnea, please. Apnea, please. Say yes.
Yes, sir.
Inject. So we can see this huge aneurysm. It's going to be really tough time, really fixing this aneurysm. Ventilate, please. Very big aneurysm. So we will have to see what we can do about the left subclavian aneurysms. Stop. The aneurysm is going beyond.
Subclavian.
Subclavian.
Yeah.
Yeah.
Let's say even beyond vertebral, I think. No, it's a carotid. That other one is feeling carotid.
No. The first one is the brachiocephalic. The second one is the left carotid. The third one is the subclavian, which is having the beaded appearance. So our first goal today will be to fix this aneurysm and see the bypass, how they are doing, how performing. As well as if required, we can, if the vertebral is good on this side, we can completely put a graft and exclude both this aneurysm and the vertebral origin. That will be a good idea.
Or we can do a carotid vertebral bypass also if required later.
Later, if required, we can do.
We'll do a carotid vertebral bypass and put a stent.
Absolutely. That's what we will do. And now the proximal bypass is beautifully seen. Come back, Peter. Come back. Come back. Come back. Come back. Yeah. Forward. 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 So you can see that the proximal part of your the debranching is just at the third ring. 1, 2, 3. In between 3 and 4th. So our graph should be starting from the 4th ring.
Yeah. From above second ring.
Yes. No, not above secondary. Your on the third, your debranching graft is coming. Beyond that, we will deploy. Yeah. So at the level of the fourth, our graft will start. The first part of the graft, which is just around the stent, we can deploy it beyond that. Let the graft, the 0-8, start at fourth.
Yes.
We have a good sealing zone there.
Yes.
All okay? So we'll start with the first graft. Yeah. So we have done the imaging now. We have seen a very large aneurysm, ugly looking, and there is also aneurysmal dilatation at the subclavian of the left. So we are going to treat this aortic aneurysm by the grafts right now. The debranching has been done beautifully, so we will go ahead with the grafting and understand how to go about it. Can we have the graft, first one?
We have two sizes, 38, 36, 28, 36, 32.
38 will go.
38, we have 32. 38, 34 we have.
Yeah, we'll go with 38, 34.
34 we have only 2 mm oversize. 2 mm.
I didn't follow what you say.
The 30th, 32 we have. Sorry, 30th, 34 we have. So we are going for the oversizing, there is only 2 mm.
Yeah.
That's why we
We'll go with 36 also. We have got a good landing zone.
31 is right, 6 mm is better.
Yeah.
Because we have a landing zone very...
Sure. So what are you giving first?
First 36, 32. 36, 32.
36, 32 is a good choice.
Yeah.
We have got a good apposition sealing zone. Right? Oh. Yeah. Okay.
That tell me, you should keep everything, no?
So the
Getting now, you keep that everything.
so we are going ahead with this graft, the 36. Yeah. 36, 32, 200 we will go ahead so that we get a good apposition, because the next graft which we are going will be on the 36, 28 we will go ahead. That will be around 160 or 200 depending on the sizing. So most likely we will go ahead with 200 plus 200, or if required 200 plus 160 depending on the first graft positioning, because the large pouch of the aneurysm, one pouch and there is another pouch, there is a kink zone. If we are able to happily cross with the first graft to the second one, then we will have good control on the second graft where we can take a shorter graft. That will be the plan. Vipul kahan hai?
That will be machine required. Our sister at London is breaking. Okay, camera expose kare paise marna padega.
Oh.
Anyway, you have to go to common camera.
Yeah.
It's diathermy not there, huh?
No, we don't use.
Is they are getting a diathermy machine?
So we are getting the diathermy, we are trying to expose it a little up basically. So the vessel at the level of exposure is not so great. We are going to go higher up to get a good caliber of the vessel. So that will take about 5 minutes of time. Meanwhile, let's start preparing the graft. So the 3632 200 graft is ready for deployment. So once we get the exposure of the right common femoral artery adequately, we will take a seat into it and then we will access so this one, right angle.
Scissors on there.
So sometime when you have an obese patient, you can have some issues like that. So once you look at the morphological anatomy of this aneurysm, you can see it very well that there are two large pouches. The one that begins just at the left carotid, and that goes on for about 10 centimeter, and then there is another pouch that comes up, that is another around 15 centimeter. So it's quite huge. 25 centimeter of the aorta has become aneurysmal, starting from the arch as well as into the descending thoracic aorta. So the challenge could be here to have the stability of the graft when we are deploying, and we are planning two different graft has to be placed overlapping each other. So this is going to be a little tricky. We're ready?
Puncture here.
Yeah.
So that we can keep clamp.
Right, so we got it exposed. So as I said that we have a team of experts working in each area, so that
Yeah.
tap.
Just above the no, not down here.
Yeah.
A little above here.
So it's very important to know each other's work so that the contingency can be managed here. Can I have the black pot with Terimo? Paroji? Then. So the whole country is in a celebratory mode today for Independence Day. Table. Table. It's always very important that we cross this aneurysm safely and land into the ascending. Can I have the land request? LV. So it will withdraw a little bit till this, yeah. Right? No. Let me hold to it, sit up. So land request is there, ready. Table please. All right. So our idea is to put our graph. It's a very stiff wire. To go in between 3 and 4. So the fourth ring, a little bit behind the fourth ring, we can start our deployment. The first graph, right? So we will prepare the graph here. Get it? No? Right? You have to hold. I'm taking out the seat.
Yeah. Seat with you. No.
Bring the blood pressure down to 60 systolic. Let the systolic blood pressure come down to 60. Team anesthesia. So you always activate the hydrophilic coating. Suction. Stepping wide. So slowly we are bringing the graph.
8 marker.
Huh?
8 marker. 8 rotate out. 8 marker. Yeah.
Can I get the screen closer to me? So we want to keep the spine up. So today we have Vinod with us from LifeTech North. So as we have discussed, our graft should start between 3 and 4. Let's check that the proximal part. Show me that the no in that picture show me the prox. Yeah,
This one, no?
yeah, that is where the
Above that.
yeah,
Between
those two.
Yes. Yeah, little above.
So on the fourth, yeah, on the fourth we will start the graft, which is exactly there.
Covered part starts from 8
Fourth,
marker.
yeah, fourth, right?
It's little bit more. Push. Because this covered part starts from here.
Oh, that's I understood. So from the covered we will start at fourth.
Yes.
Because you bring the screen closer to me. See, this is our
This
take
is
care,
enough.
take care. Yeah, that is the anastomosis. Yeah.
This is enough.
So we will start the graft from here.
Cross this, or you have to keep
Yeah, it's better to cross.
Better to.
So we will just cross it as we deploy. We'll withdraw. Yeah. So this will be good for us.
8 is where now? 8
No,
is
yeah.
here.
That, at the fourth. 1, 2, 3, 4.
1, 2, 3, 4.
1, 2, 3, 4. If you want, we can take another run and see. What's the big deal? You have enough time. But are you ready?
From there means it is okay.
Yeah, we'll just take one confirmatory run. Creatine is fine. No. But are you ready? Apnea, please. Inject. Oh, yeah, this is much better. Ventilate. So we are far. Stop. Wait a minute, Vinod. So we are quite at the root with the. See, come back one. So between these two. Exactly where you have put the line. Run the plate, beta. Next one, last one. Yeah. So between 2 and 3.
Yes.
Okay. So we should, we can come further, and we will start our graft at the level of the 3. Okay. Because of change of angulation, it has changed. Because we took that extreme angle. This is where we'll start. This is where we'll start. This is perfect.
Where is 8 now?
8 is there.
Third.
Third way.
From there cover will start, no?
Third. This cover will start after the anastomosis. Third. Good.
This is cover part.
Okay.
Anastomosis at second, you are telling?
Yeah.
Second is anastomosis.
सेकंड एंड थर्ड के बीच में एनास्टोमोसिस है. थर्ड से हम लोग ग्राफ्ट शुरू कर रहे हैं. BP is under control. I'm going ahead with the deployment of the graft. So we're quite close to the aortic arch with this nose cone. Beautiful, right?
1 to 20 fast.
Yeah. Up to the 1. Okay, good. Ready? Maintain the blood pressure, beta. Okay, we're done. So thank you. So the first graft is done, and we are across that the ridge between 1 and 2. So beautiful. We just loved it. What a beautiful anastomosis has been done by Bhai, and the graft has been exactly placed beyond the anastomosis. So now we'll open and deploy the nose hum. Okay, bye. So perfect. This part is done. So can we take a small run and understand? Make it 15 ml. Volume 15 ml कर दो. नहीं वो ठीक है. नीचे का. So I hope the whole thing is very clear about what we are trying to show. Are you ready? Okay, I will request for apnea again. Apnea, please. Inject. Excellent. So ventilate, please. So beautifully done. Can you show the screen here? So now stop it, Prasad. Stop it for a moment. Yeah, stop. Okay, save it here. So you can see that beautiful the proximal anastomosis of the debranching graft, and our stent is just across this the anastomosis proximal debranching graft. Our graft portion of the endovascular stent is starting just beyond it, where we exactly wanted to place it, and our distal portion has the stent has covered the first part of the aneurysm. You can compare the aneurysm in the first part of the aorta is gone completely. We're super happy about it. And now we will try to treat the second part of this aneurysm, and this is so far so good. Thank God, looks much beautiful and wonderful. Right. So I need the next graft now. Right? Let it be engaged here. Let's prepare the next graft. Now momentarily you can improve the blood pressure. कौन रोज
opening upper jati opening अच्छे तल पाटे
से जो किंग को अच्छी से डोटे that's why the stent is hinging here. We are happy.
you want to check length?
Yeah, we'll check a length. Yeah, table please.
It's a wire and no, then that is narrowed. Is it narrowed or normal one?
Narrowed. Not much narrowed. It's about 22.
22.
Yeah.
So with the other stent, will it open up?
It will open little bit because we don't have the stent graft having a lot of radial strength. That's not the purpose of it. So it should not also try to do that, because in a aortic dissection it might rupture and all. But it will have enough length, and slowly as the time progresses, it will have its normal course. So
the remaining 2.2 also should be okay.
It will be okay. It will be okay. It will be perfectly okay. Yeah. So we will try to do a measurement for the appropriate sizing of the second graft here. So, Paroji, table please. Can I have the screen closer to me? Give me the wire. There you go. हाँ? उसको इसको हम ये कर देते हैं. Right here.
Wire please, wire push करना. Wire push करके रखना.
So we will have to take it to.
थोड़ा पुल करो, ग्राफ में टच हो रहा है.
Oh, we have to.
पीछे कर दो सर, पूरे डिवाइस.
कोई बात नहीं, कोई बात नहीं. So we have to take it to a straighter portion where we can reset it completely and hold it here. Till that time, we take the measurement of the next graft.
ये स्टेरल है.
Sterile. Paraji, ready? So what we will try to do, which is a little tricky though, is trying to take a measurement of this portion, which is not going to be any simple here with another graph sitting there. So to understand the measurement better, I am trying to so give me the what black 40 remove. Pictel ta bahar kar deli ame 8 hone kina gote measurement kariba so that whether 16 is enough or 20 has to be taken, that we will see. So 20 nele we will have to have overlap till here. 16 maybe little less. So we try to understand to safeguard as much intercostals as possible. We'll try to do that basically. So here, because the anatomy is very complex, so it was very difficult for us to decide the sizing of the second graft procedure. So we have decided that we will so we have gone inside. So this is what is very important when we are doing these procedures, to be able to navigate there. Otherwise we'll change it over to pigtail there on that one. And plus superstate. So we have navigated our catheter inside the graft. Here inside the graft, we will take a pigtail. We will take a run with a marking pigtail, which will give us a measurement exactly. And the first graft we are maintaining, basically the delivery system of the graft we are maintaining. Here we take a marking pigtail to understand the measurement of the second one. Table please. Right. Stop. So that will exactly tell us that what size of the graft can be taken. Mag 1 taku. You have enough contrast, or otherwise load it. 64 ml is okay. 1 mag. So we have taken the marking pigtail here, which we will leave it here exactly. Here we will take a run to understand what size of graft will be appropriate for us. बेटा थोड़ा सा फॉरवर्ड करा, little. Every step is very important. First stop. A drop of air can be catastrophic going inside the brain. So we are ready to take our next run. Table please. Srinu, our smart boy, is on job. He was not happy to come on Independence Day, but thankfully. Okay, I will request for apnea. Are you ready, Prasad? Apnea, please. Inject. So you can see the second part of the graft very clearly now. Ventilate. Now we will mark our celiac, which has to be protected. Prasad beta. Stop. That is SMA. SMA and celiac. Yeah, correct. Celiac. Okay. So you can see how big was the aneurysm. One part of the aneurysm treated. Huh?
16 is up to here.
Not a good idea.
I think 200 is good.
200 is a good choice, because we will have a good overlap. At least 4 to 5 centimeter of overlap will be good. And we will have this fixed. Table is fixed. So we will take in this position. And our primary goal is to look at the distal portion.
So to take start now, push more because we will not need to come 3 centimeter.
Not celiac. At least
4 centimeter only.
Right. At least 3 centimeter we have to do a close-up.
1 to 3 centimeters. Yeah. So up to here should be okay. So from there,
We might lose some length into this part. It's not straight like that. As you deploy, it will overlap. So you lose some length. So then it will get pushed. So your end of the stent graft will be.
About the spinal artery.
No, that we can give any amount of overlap. That's not a problem. We'll try to finish it up here. Yeah. That's all. Okay, can we go with the 20 graft?
Yes, sir.
Yeah. So let's prepare the graft, then we will take the delivery system of the first one.
The 16 what is the problem?
16, first of all, we will not get enough overlap there. And if the graft is not coming like this wire, if the graft takes a little curve because of this extra space available here, then that will force shorten. If the graft is coming straight like that, 16 is great. But if the graft takes a little bit of loop, you lose length. So it's a 36, 28, 200, and we have a 32 distal diameter of the first graft. So we got a 4 centimeter of the 4 millimeter of this overlap, which is fantastic. So the chance of endoleak will be very less, and we are giving almost like 5 centimeter of overlap into the first graft. So we hydrate the entire system to activate the hydrophilic coating, and please come. You will remove this. You maintain the homeostasis, right? Heparin दे दीजिए. You mark it, right? Show me the last one.
You will take another one.
The table is fixed. Okay, we can take one more. Yes, bhai. Okay, bhai, I'm coming out.
Wait.
So, maintaining the wire where we should. It has been taken out, and we are ready with the second graft. Can we give some more heparin? ACT check karo.
Yeah, outside is a get quickly.
Yeah. Can I have the second one quickly? So to reconstruct such large aortic aneurysm is really challenging. So the entire team of people, I'm going, yeah, are working really in good harmony.
Post that.
Yeah. We are gone. So we are trying to. Yeah. We'll do that. Perfect. So as we see, folding the wire, Paro. See this? This is also, I mean, appropriate.
Yes.
Actually, 16 will be too short. Table, please.
The last part.
Wait. Table, please. Table, please. Exactly. This is a good view. Here we will take. All right. Can you take it out, Prasad? I have to speak louder, I think. हाँ हम लोग एक रन करके फिर डिसाइड करेंगे. रेडी? आपने यहाँ प्लीज आपने यहाँ प्लीज प्रसाद इंजेक्ट.
Spinal aortic.
Go slow, Prasad. Slow. Yeah. That is where we have to end. Okay, now. That's all.
Yes, quite good length is there.
This is how we will start.
Yeah.
Okay, na?
Okay, sir.
That's very good. Perfect. So please reduce the BP. Blood pressure reduce कीजिए. Systolic to be brought down to 70. I'm going it up. So everything looks in place. No, everything fine. Everything is fine. Did you see? It is automatically got pushed up. So if you take a shorter length, this will be a trouble. So we are done with the second one. Fine. So now we will pull out the pigtail, take the pigtail inside and try to see. We have deployed the second graft meanwhile. Huh?
No,
No. So we have released the graft.
just pushing, sir, pushing. Yes. Wire push, please. Wire.
Wire का push. So we have captured. Bas. Paraji, stay there. Tell me. So we'll take the pigtail and so I brought it from among the grafts. अरे स्क्रीन को देखा हमको देखे किस टावर है हाँ? So now we are trying to take a final run. So I have some challenge here. Yeah, it's good. See portion जो कहते ना भाई, that is definitely little king, but we will not address it right now. Give me a bot and tell me. We will cross it, then we will.
No, that
Yeah.
centimeters is there.
Yeah.
It's okay.
So we have reconstructed it with two grafts, which look stable. We will take a final run before concluding. And the anastomosis is working so well. So if required at the end of the procedure, we can do a transradial angiogram from both right and left. So we have taken this, and now we will take the pigtail over this wire. Give me the pigtail. So, bhai, the first graft distal end is into the aneurysm. Now we are trying to reconstruct it in this way. So a good grip proximally and distally is most welcome. And if you look at that marker here, है ना, marker की just about the next vertebra में हम लोग end किए यहाँ, which is good apposition. At the same time, not close to the celiac anyway. Out now. So now we will get a picture of what we have achieved so far. Prasad, little more contrast should be good. Okay. Aspirate a bit.
Aspirate.
Ulta, ulta, ulta. Why are you doing anything? So we try not to cover. ऐसे करो, ऐसे करो. 29 तुम यहाँ पुश करते जा रहे हो, छोड़ दो,
Pull करो, pull करो.
छोड़ दो.
Pull करो.
Yeah, good, stop. Very good. So go ahead now. 15 ml with a, yeah. So I will request for apnea here. Apnea, please. When inject. See this? Beautiful. The aneurysm is completely gone. The SMA is filling. The celiac is filling. Ventilate, please. So this is a perfectly executed case. What do you say, Vinod?
Perfect, sir. Perfect.
Beautiful apposition and beautiful exclusion of the aneurysm. Stop, Prasad, stop. Yeah. Yeah, beautiful. That's all.
Good.
So this is an excellently executed procedure for the part 1, the debranching, and the part 2, the endovascular repair. So Bhai will give an insight in a minute about the debranching that was done, and I will give a closing remark in 30 seconds.
Yeah, the procedure went very smoothly, both the surgical part and the interventional part, and both are very important part of this hybrid procedure. So we have debranched the neck vessels, as I told, and those things also working very well, which is shown by angiographically. And Dr. Dalai has put 2 stents in a very excellent way, and the aneurysm is totally excluded, and the debranching grafts are flowing well, and down above celiac it is there, so the abdominal vessels are perfect. I think it is a wonderful case, and we have done it very perfectly.
So we started with this case with the large aneurysm, which was starting from the distal part of the aortic arch going down to the thoracic. So there was a requirement to do 2 procedures. One is a hybrid, one is endovascular. The hybrid was done as Bhai has discussed. The endovascular procedure challenges were because we have to graft right from the anastomosis, which has been done this morning. Must be careful, which is very close to the heart, so the pressures are quite high. And at the second time, the aneurysms are so large that you may get lost with your distal part of the graft when it's coming down. So everything has been well controlled and well done. So nicely done procedure. Thank you very much for watching or listening to this, and we are hopeful to show you soon something beautiful again. Thank you so much. Namaskaram.
Thank you.